my name is Rosie Quibel and I'm one of the InWork Support's Health and Work Occupational Therapists, and I'm joined today by my colleague Jan Burke, who is a research occupational therapist within the team. We're here today to talk to you about providing an occupational therapy wellbeing service for working people in GP surgeries, a summary of early outcomes and lessons learned.
Hi everyone, I'm Jan, and I'm going to start just by giving a bit of context to the GP pilot we're going to be talking about today. The pilot is an extension to an existing project called the InWork support service, so we thought it'd be useful to tell you a bit about that first, just to set the scene. So the InWork support service was established in September 2015 with European money via the Welsh Government, and it's currently funded until 2022. It operates in the Bridgend, Neath, Talbot and Swansea county borough areas, and it's delivered by a team of occupational therapists and physiotherapists who are all employed by Swansea Bay University Health Board. We provide free and confidential support for working people who have commonplace health disorders, so that's to say musculoskeletal problems or muscle or joint problems, and or mental health conditions such as stress, anxiety, low mood or depression. And the aim of the service is to enable people to manage their health problems more effectively so that they're able to continue to work and don't fall into worklessness. We offer one-to-one support, usually over the phone, although prior to the pandemic, people could also choose to have face-to-face appointments if it was necessary or if they preferred it that way, or they could access a 5-session wellbeing course that we provided if that was appropriate for them. Obviously, since the COVID restrictions, the face-to-face appointments have ceased, but we are working on delivering the wellbeing course in a different way, as well as some face-to-face sessions using Skype or MS Teams, that kind of thing. Rosie will be talking a little bit more in a moment about the sorts of interventions that we offer. And historically, people have usually referred themselves to the service by phoning us directly, although we've had some referrals through from employers and GPs and others. However, over the years, we've tried different ways to engage more with GPs, and we felt that we could be working more closely with them. And that brings us really to the pilot that we're here to talk about. So I'll pass back to Rosie at this point, who's going to explain more about the pilot.
There we go. So as Jan said, this pilot we often referred to as the GP Inreach Pilot. So this was a 6-month test of concept which started in October 2019. Myself as the OT was based within a GP surgery for half a day per week, and referrals came from the GPs directly via the practice manager who populated the calendar. So within the appointment that was provided, this was approximately a 30 to 40 minute assessment of the patient's needs and goals, and brief intervention would be carried out. So things like education, self-management techniques, such as those principles taken from cognitive behavioural therapy, acceptance and commitment therapy, maybe some mindfulness. And where appropriate, we discussed return to work advice and recommendations. So this could have been verbally, actually in the appointment itself, or through the allied health professionals' health and work report. And where necessarily, as usual, signposting was considered to other services that might be appropriate and resources such as intervention sheets. Consideration was also given to the need for further OT appointments, maybe to review a return to work or to further work on some of the self-management techniques, or the possibility of them requiring some physio input. So this is where a referral into the full InWork support service that Jan has just described would occur. And following this, we did actually expand into a second surgery in January 2020. And a further 2 surgeries were very interested in the work we were doing. So discussions were being made and had prior to the COVID-19 lockdown as to how we could move forward and work with these surgeries as well. And just to mention as well, the physiotherapists in the team were also in the early stages of providing a similar service elsewhere. So moving on to some of our outcomes then. So one of the first outcomes that we noticed from the service was that we were able to offer a more streamlined service. Recognising that prior to the project, participants would usually access their appointment over 5 steps. So this included a GP appointment, a referral to the primary care hub, meeting with a primary care advisor, signpost to our service, and eventually getting to our service. We were able to reduce the patient pathway significantly through a GP appointment, a referral to the OT, and an appointment with the OT, usually within the same building. And Another outcome that we noticed was a reduced need for GP appointments. So during our sessions, patients would often discuss their plans, whether they needed to return to speak to their doctor and why. And this provided an opportunity for me to offer an intervention or advice as appropriate to reduce the need for them to go back to the GP. So one example of this, I met with a participant who informed me that they'd been struggling with their sleep, so they wanted to discuss this with their doctor. I asked if they would like some ideas of some sleep hygiene techniques and signposted them to NHS Choices as well. And they took this information on board. We had a review and they reported that the information was sufficient and they didn't need to go to their GP. Another outcome that was noticed as well was around evidence of an enhanced service provided. So likely due to the nature of a longer appointment provision and the opportunity to build rapport with the patients, barriers to health and an ability to return to work were able to be addressed directly and in some detail. So an example of this, a patient who was referred to myself, I could see from the clinical records, had regularly returned for an appointment with their GP over a short space of time. When this happened, it was reported on the clinical system that the person wasn't able to discuss their health needs and requested an extended fit note, and this happened over 8 occasions. So during our session, I was able to build rapport with the patient. They were able to disclose their diagnosis of dyslexia and some of their fears of the workplace becoming aware of this diagnosis. We were able to address their concerns and their avoidance of work and signpost to some dyslexia support services also.
So as well as those really important qualitative outcomes that Rosie's just described, we also have some other outcomes that we'd like to share. My role in the project has been really to oversee the collection of data to enable us to evaluate the pilot. So I'm going to run through some figures quickly to give you an idea of some early outcomes. So first of all, in terms of numbers of people accessing the service, 38 individuals were seen since it started in October last year until we had to put things on hold, unfortunately, at the start of lockdown in March. So that's approximately 20 weeks in total. And that works out about 2 people a week on average who were seen. Bearing in mind that Rosie was in the surgeries for just half a day a week, so that was quite a good uptake. There was an average of 1.5 sessions per person, so that was about an hour of Rosie's time, just to give an idea of what the input was involved. So it was relatively modest, really. And 21 of those people, those 38 people, went on to access full InWork support service. So it's likely that they, or at least many of them, wouldn't have received that support if they hadn't had that easy access to the service via that first appointment with Rosie in the GP surgery. And during that time, Rosie produced 3 AHP health and work reports containing recommendations to make it easier for individuals concerned to return to work and to sustain that work as well. And again, it seems unlikely that they and their employers would have received that advice otherwise. And we'd also just quickly like to share some health and wellbeing outcomes. So everyone who accesses the InWork support service, whether that's in the traditional way or via this pilot, it is asked to complete an EQ5D assessment. So as you may know, this is a standardised measure of self-reported general health and wellbeing, and it includes a visual analogue scale, or VAS for short, which is like a temperature scale with 0 at the bottom representing the worst health imaginable and 100 at the top representing the best health imaginable. So that assessment is completed at the start of the initial assessment and then again when the person is discharged. And as you can see from this chart, the average or mean score for the 38 individuals that were seen via this pilot was 56 at referral, and that had increased to 80 at discharge, so quite a notable increase. And looking at work outcomes as well, as you can see again from this chart, 26 of those 38 people that Rosie saw were on sickness absence at referral, so that's about 68% of the people she saw, and by discharge that had reduced to 11 people, or about 29%. So again, some really positive outcomes there. And although these figures should be interpreted cautiously, as we can't claim to be sure that these improvements are solely due to the intervention through us, it does, however, coupled with the positive feedback that Rosie received from people she saw, it does indicate that there were positive outcomes at this early stage, and especially considering that they were achieved with that quite modest outlay of expense and time. So as I said before, about an hour of Rosie's time per person. So these are really encouraging early outcomes, we think.
And just considering some early lessons learned as well. So the first one to mention is how communication was pivotal to the success of the pilot in its early stages. So initially, networking opportunities were required to identify interested parties, such as the GPs and the cluster managers. And we also learned about the significant role of the practice manager, their ability to organise, to pull all the pieces together which were required to make the project a success. We regularly attended the MDT meetings at the surgery when possible to present to the team, discuss referrals and processes and expectations on both parts. And comparing the two surgeries we began work in, we quickly identified the surgery where we had more of a physical presence, such as being based in the same building as opposed to an external venue, provided much better communication, referral rates and awareness of the service. Proactiveness as well was essential, as the project was initiated by us and required that maintenance and management to keep it going. And we also learned that despite a clear message, inappropriate referrals will happen, because they did happen. So it's important to relay the service provision and understand other pathways for patients to access the input that they require, always relaying those parameters. And finally, regarding communication, we learn about how the GPs communicate through their own clinical records and how to adopt this. So where we were based, it was the vision system. So it was about learning how to use this and to communicate effectively with them. Aside from this, we learned that the use of the allied health professionals' health and work report was a unique selling point to the GPs. They would often comment that they saw this as an opportunity to save time in writing their own recommendations, as sometimes they were able to do that in brief using the fit note, for example, for a phased return to work or altered duties. And they were very interested in the level of detail we could provide within the report and the impact that this had on the return to work rate within patients' experiences.
And another lesson we learned was the importance of thinking about evaluation at the outset. So we put quite a bit of thought about what outcomes we were interested in and what data we would need to collect. And we also consulted the GPs in the practices involved as well to ask what they wanted to measure and what would make this pilot a success in their eyes. And then lastly, another important lesson we learned was about lone working and the importance of doing an adequate risk assessment. So Rosie was usually allocated a space to work in within the GP surgeries, but in one case she was in a separate building with only one other person on site. So she was potentially quite vulnerable in that situation, and we needed to manage that. So again, that's something that from our experience we realised was a really important thing to carry out an adequate risk assessment and manage those risks properly. Thanks for listening, everyone. That's the end of our whistle-stop tour of our GP Inreach pilot. We hope you found that interesting, and thanks very much for listening. And thanks to the organisers for arranging this event and giving us this opportunity to talk about our work as well. If anyone would like to contact either of us to know more, our email addresses are on screen now, and we'd be very happy to talk to you. And just want to say thanks again for listening.